So good morning, everybody. I would like to introduce Josias Grock. He's a first-year resident in our department, and he will talk to us about anorectal fistula this morning. Go ahead.
Thank you, Dr. Kabelsar, for the kind introduction. Dear colleagues, welcome to this presentation this morning. I will talk on the topic of anorectal fistulas. So I will start with a quick overview of and summary of the subject, and will mainly focus the presentation on the surgical treatment, especially with a focus on the complex and the Crohn's fistulas. And to finish, I will talk a little bit about the new stem cell treatment. So the definition fistula, it's a Latin word meaning tube or pipe. It actually also refers to an ancient type of shepherd's pipe, as seen here on the right. But according to the medical context, fistula is an abnormal connection between two hollow spaces. And specifically, an anal fistula is the non-physiological tract or connection between the anal canal to the perianal skin. Anal fistulas have probably been around since mankind exists. That also is shown with documents of the history, as seen here in this ancient Japanese painting called The Man with Many Anuses, dating back to the 12th century. And also descriptions on the treatment of anal fistulas date back to probably the father of medicine himself, Mr. Hippocrates, which published around 800 before Christmas a detailed description on how to treat anal fistulas. And interestingly, he described the use of horsehair, in Greek seta, to drain the fistula and then the regular washing of the wound. And this treatment actually is all still used today, although the seta is now called the seton drainage, but it's still an important part in today's treatment. The patients usually present with non-healing chronic anorectal abscesses. With that, they have anorectal discomfort or pain during defecation, sitting, or other activities. Depending on how bad the infection is, they can also have fever, they can have swelling. Also, with the chronic irritation of the skin, the patients usually present with pruritus ani, with itching skin. And of course, there can be bloody or purulent drainage from the fistula canal. Diagnosis is usually done by examination, nowadays done under anesthesia. We perform an anoscopy and the fistula tract is probed and identified. Nowadays also for the more complex fistulas, and especially in the Crohn's patient, it's very important to identify the exact fistula canal with MRI or with endosonography. When talking about diagnostics, I want to make a quick remark. One of the most asked exams question on the topic of anal fistulas is the so-called Goodsall's rule, just a quick reminder for everybody that maybe has an exam soon. It states that if the external opening is anterior of the transverse anal line, then usually the fistula tract is straight, and if it's posterior, then usually the anal canal is in a curved motion. This is true if the external opening is within 3 centimeters of the anal verge. And as a reminder, you see on the right this image of this dog with the straight nose anterior and the curved tail posterior. Of course, nowadays with newer diagnostic modalities, the Goodsall's rule is not that important anymore. Where do the anal fistulas come from? The majority of the patients have a chronic infection of an anal crypt gland. As you see in here, the crypt is infected, and this infection goes the way of least resistance down, right through the sphincter muscles or up, and by that, chronically, anal fistula is formed. Also, an important cause is the Crohn's disease, where it's rather transmural inflammation than an infected crypt gland. But also these patients, especially after long years, after 20 years of disease, up to 30% of the patients present with anal fistulas. There are other reasons for anal fistulas, for example, damage due to radiation proctitis. Also, erectile foreign bodies, as seen here on the right, can be a cause. And chronic infections, for example, a chlamydia infection or anorectal tuberculosis. The true prevalence of the fistulas are not quite clear. A study showed that when looking at the patients of the general practitioners, up to 15% when asked directly have anorectal discomfort or anal or symptoms that could be caused by an underlying fistula. But a prevalence study in Europe in 2019 showed that the prevalence is around 15 per 100,000 a year, but the authors state that probably this prevalence is understated. The median age at diagnosis is around 40 years, ranging between 20 and 60 years, and men are twice as likely to be affected by this disease. So let's go over and talk about the classification, but first we need to clarify a little bit about the anatomy, and that actually might be a good question for the medical students in the room. Could you assist me and help me identify the important structure? Maybe start with this one.
I believe what you asked is the so-called linea dentata, which separates the end passage of the rectum and the rest.
Very good, thank you. The dentate line, excellent. Also important for the classifications are the muscle structures. So here on the inside, it's the internal sphincter, the external sphincter, and also the levator ani muscle. Maybe another question for the audience, probably now for the surgical residents. Do we know, or do you know any types of fistula classifications?
Inter and trans or extra and super sphincter.
Perfect, very good. So, as you said, with the Parks classification being the most famous one, the most frequent is the type 1 intersphincteric fistula. There's the transsphincteric fistula, also the suprasphincteric fistula and the extrasphincteric fistula. And maybe an extra question, do you know other ways of classifying or differentiating between fistula types?
You can differentiate between simple and complex also.
Very good, thank you. Actually, the Parks classification is quite dated, dating back to around the 70s. There's newer classifications, for example, the St. James or the newest, the Garg's classification, and they don't only describe the anatomical relation of the fistula tract, but also differentiate between simple and complex fistulas. And they also give guidance on what would be the optimal treatment or how these patients should be treated. And with that, we arrived at with the topic of the treatment of these fistulas. So what's the goal? Of course, we want to heal the fistulas of the patient, but we also want to prevent recurrence, and we want to preserve the continence of these patients. And overall, we want to improve the life quality. So as stated before with the classifications, for patients with simple fistulas, meaning there's no significant sphincter involvement, they are superficial or low transsphincteric fistula. Usually there can be a surgical treatment with a fistulotomy showing good results. That's also reflected in the current clinical practice guidelines. Here an example of the American Association that states that for simple fistulas, fistulotomy is a recommended treatment option. Real quick, fistulotomy, the fistula tract is identified. It's important to identify the inner opening, and then it's laid open surgically, and usually then an open wound treatment with wet on dry packings and regular washing of the wound is applied. There is a big multi-center study with over 500 patients treated with fistulotomies. This study states a primary healing rate of around 80%, and a secondary healing of about 90%. I want to emphasize that different types of fistula were treated here, and especially the more complex type, the transsphincteric fistulas, had worse secondary healing rates. The study also looked at the long-term healing rate being about 80%. So as seen here in this Kaplan-Meier curve, a certain percentage of patients after 5 years will show recurrence. So let's look at the other patient group, the patients with significant sphincter involvement, the patients with complex fistula types. There we need to use sphincter sparing procedures, and also due to the more complex fistulas, healing rates are also not as good as with the simple fistulas. The guidelines state different sphincter sparing procedures. I want to introduce the advancement flap first. Here also the inner opening is located and resected. Then it's closed mostly with sutures, and then a mucosal flap with healthy mucosa, submucosa, and usually with some muscle fibers of the internal sphincter is mobilized, and then by that this inner opening is closed. There's a big meta-analysis with over 2,000 patients treated with advancement flaps, reporting healing rates between 60 and 87%. Also, the study shows mild to moderate incontinence rates in these patients with up to 35%. And another meta-analysis published in 2015 also states that so far, comparing the sphincter-sparing procedure, the advancement flap is the best evaluated procedure with most randomized controlled trials on the topic. There are certain factors associated with flap failures. Of course, if the mucosa is already damaged, for example, prior radiation, damage with Crohn's disease, active proctitis, but also previously surgical attempts for repair are associated with flap failures. Also, this newer meta-analysis states that some articles they stated did not report or document the surgical technique properly. So it's important, as I stated before, this anal crypt glands are usually located at the dentate line, and of course the flap should cover the dentate line. A newer sphincter-sparing procedure is the ligation of intersphincteric fistula tract, so-called lift procedure. There, the fistula tract is identified in the intersphincteric plane. There, comparable to a ligation of a blood vessel, the tract is ligated proximal and distal, and then divided. Also, the use of a ceton drainage before the lift procedure is recommended. There's also a meta-analysis on this technique with over 1,000 patients. Healing rates range between 56 and 87%, as seen over here in the pooled data. Fecal incontinence is rarely stated in these patients, and actually the use of this ceton drainage before the lift procedure, could not show any difference in success rates. Factors for lift failures are a longer fistula tract, longer than 3 centimeters. Again, previous attempts in surgery, and obesity. There's a randomized control trial comparing the two procedures. 70 patients were included, 35 per group, and there were no significant differences in healing rates initially, but also after 1 year, seen here. Although the lift has a higher percentage, there is no significant difference between the two procedures. The lift has a significantly shorter healing time, though, with 26 years compared to 38. Concerning the continence of the patients or the quality of life, there were no significant differences between the procedures. So when we hear healing time of up to 35 days, of course, there were also attempts to find minimal invasive or biochemical treatments for those patients. One example is the fistula plug. It's a collagen matrix plug that should promote the growth of the patient's own tissue to close the fistula. Early data published in 2016 were very promising, with healing rates of above 70 to 100%. But more recent data with long-term outcome are less promising, with less than 50% healing rates. That's why right now the fistula plug in the guidelines is stated as being relatively ineffective. Another minimal invasive and biochemical treatment is the fibrin glue injection. It also was introduced in the late 90s, early 2000s. There's retrospective data on the treatment with a big range of success rates between 14 and 63%. Now also a prospective multicenter trial, it identified healing rate was about 39% after 1 year. And with that also right now the guidelines state that the treatment is rather ineffective. One last word on a minimal invasive treatment. It's a newer one, the over-the-scope clip, or short OTSC. Actually, the device was before used to treat injury or lesions of the bowel wall endoscopically, and a German company changed this device and modified it in order to be used on anal fistulas. As I said, the German company produced it, so it's also a German group, Prost et al., that publishes most data on the device. The so far biggest study with 100 patients treated like that, published in 2016, showed healing rates of about 79%, although they were less successful in recurrent fistulas with 26%. And also they state that they have success rates of up to 45% with inflammatory bowel disease, although the patient number is very limited. If you look at the literature beside this group that used this technique, again, the success rates vary very much in between 18 to 99% of success rates. So right now, I want to repeat, the guidelines state that as sphincter-sparing procedure, mainly then endo-anal advancement flap or the lift procedure are recommended. These are also the main procedures performed here at our center. So let's finish the presentation with a little information on treatment of the Crohn's fistulas. So Crohn's disease, it's a chronic inflammatory bowel disease. It's a transmural inflammation that can manifest anywhere along the gastrointestinal tract. The perianal Crohn's disease is present in around 25% of the patients, and those patients usually have to undergo multiple surgical interventions in order for treatment. But still, about 40% of the patients are left without the definitive surgical treatment of their fistula, so they either have a lifetime of active disease or ultimately will receive a prostatectomy. The treatment of the anal fistula, since it's an other etiology, it's also more complex, often multi-interdisciplinary. Generally, the guidelines state that asymptomatic patients should not primarily undergo surgical therapy. And when the patients get symptomatic, there's a certain sequence. First, you have to eradicate the acute infection with antibiotics and maybe with placing aceton. The status of the luminal Crohn's disease has to be assessed and improved. The fistula anatomy has to be assessed carefully, and with that, the optimal surgical treatment has to be chosen. Also, with these patients, fistula closure is not always the ultimate goal. Also, symptomatic improvement can be the goal of the treatment. So here I switch to the ECO guidelines on therapy of Crohn's disease. Up above the two first points here, it's again the two sphincter-sparing procedure, the flap and the lift procedure that is recommended in Crohn's disease. The authors also state that the fibrin glue may be a potential treatment for those patients, although of course also for the Crohn's disease patients with limited efficiency. But there's a newer promising treatment. As I stated in the introduction, the adipose-derived stem cell therapy with injection of the stem cells. Real quick on the basic science. So those stem cells, they exist in almost all the tissues. They reduce inflammation due to intrinsic immunomodulatory properties by secreting anti-inflammatory molecules. And by that, they have paracrine signaling to nearby cells and upregulate especially the CD4+ regulatory T cells, which are known to be deficient in Crohn's disease. So experience with those adipose-derived stem cell injections, mainly the early ones come from Spain. Here, phase 2 and later phase 3 trial by Garcia Olmo, which showed significantly better healing rates for the patients with the newer treatment compared to the fibrin glue. From that, now 2016, published in The Lancet, the Admire trial by Panis et al., where they now used allogenic stem cells injected, which also showed significantly better healing rates than the control group, even after the longer follow-up of 52 weeks. This product is now also available commercially, the Alloficell, introduced in Switzerland in the late 2018. It's for treatment of complex perianal fistulas in Crohn's disease patients after they had inadequate response to at least one conventional or biological therapy. It's available in 2 centers, here at the USZ and in Lausanne. And I give you a real quick overview of the experience we have with the medications so far here at the USZ. Up to now, 11 patients treated with Alofisel, 1 last week. We'll come to the follow-up this week, and success rates of about 80%. So far, only 2 patients, one with recurrent disease and one with no primary healing so far. So to conclude, surgical treatment for fistulas show good results concerning healing and continence rates for the simple fistulas, but the surgical therapy of complex and especially the Crohn's patients is complex. There are no clear guidelines which one is the holy grail, the one treatment that fits all, so therapy has to be chosen very carefully. Also, maybe remember that no primary surgery should be done on Crohn's disease patients if the fistula is asymptomatic, and the stem cell therapy shows promising results in early trials. Thank you for your attention.
Thank you very much for this overview. Important disease, frequent, huge costs for the society, and quality of life. You have only 3 questions. First, a little bit what we do here. If you're not in 2 or 3, we have seen the level of evidence, what's going on, maybe just a close summary of what procedure do you select here for the patients. Next questions is, this is common procedures done by many people, surgeon or non-surgeon people, which case should not be done by them and refer to a centers where we have expert in the field. We cannot treat all fistula, but which one should absolutely be referred to the expert. And the third question, maybe to Professor Turina, I mean, this is very appealing, these stem cells. I'm happy it's done here, but there is a huge cost to this. I think it should be a comment about the cost and who should pay and who should have it, since healthcare economic is very important today.
So for the first question, depending on the fistula classification, we perform for simple fistula the fistulotomy, where there's not a lot of sphincter involved, and the lift in the mucosa flap. In special case, we also use the OTC, the over-the-scope clip, but these are rare cases. The plug we nearly left. Yeah. What we also did is the fistulotomy with a primer sphincter repair with also good results. The second question, patient, I think you must have a good experience treating this patient. Also, if you have a patient with complex fistula, with recurrence of the fistula, or if you have patient with Crohn's disease. So especially the last group of patients should be sent to a center. And I can also have a quick overview for the last question. There are clear classification with patient qualified for this treatment. Yeah. And if they fit for this treatment, you can try to get a cost from the insurance that they cover this treatment. But unfortunately, we have here the highest problem to get this coverage for the treatment.
What's the cost?
About 17,000.
Thank you very much. Beautiful presentation. I'd just like to add one thing regarding the selection of operations. You've shown us that there's quite a list, there's quite a range, and whenever there's a range, it really makes us curious as to which one may be more efficacious than the other ones. We know that fistulotomy is by far the best treatment to treat any fistula. So if you can do a fistulotomy, it will heal. The question is just how much sphincter is involved. If you do your fistulotomy too high, your patients will be incontinent. So one of the modifications that came up within the last 15 years was to do fistulotomy on essentially all patients and then go for primary sphincter reconstruction. which is very simple. You just suture the sphincter defects and close the mucosal lining above the sphincter. And surgeons were very hesitant to do this operation, except for one professor in Germany, Professor Herold in Mannheim, who's taken this on, who's published widely on this topic, and who's had good results. We've taken this on in Zurich as well. We've done a number of these patients, and also in our experience, that's a very good treatment strategy for some patients. Not as a primary operation, but in failed fistula repairs, that may be an important one. So fistulotomy with primary sphincter repair, I think that's one of the operations that will see more focus in the coming years. Finally, stem cells. Stem cells are very expensive, 70,000 Swiss francs. That's one of the emerging strategies now. Whether it's still going to be around in 10 years, we simply don't know. I think there's a value or an importance for two things. One, of course, is interventional studies, randomized studies, ideally. The second one is registries. We're participating in the Takeda registry in Zurich. OSZ has the greatest experience of Alofisel treatments in Switzerland, even though it's only 10 patients so far. That's one of the higher numbers, even in Europe, to my surprise. And that is simply because Alofisel is so expensive. The first series that were published in Spain were biased in the fact that the treatment was paid by Takeda itself. Once outside of Spain, individual patients or healthcare insurance companies had to come up for those costs, which is the reason why so few have been done internationally. And the final comment about this high price is just when we consider the potential secondary or alternative options that we have for these patients, Crohn's disease patients, severe fistula, recurrences problems. Eventually, many of these patients will undergo proctectomy or abdominoperineal rectal resection to control their disease. So if we would manage to treat their fistula problems with measures that will ultimately not lead these patients to abdominoperineal amputation, then I think that is something that would also save money in the long term. So these are our thoughts on Alofisel. We believe we're still in the experimental phase with Alofisel. We're happy to contribute in Zurich, and we'll see where the path goes. Thank you again. Other questions? Fistula treatments in Germany. You've had some experience with fistula treatments in your time in Germany. What are the preferred methods to treat fistulas there?
As you just mentioned, it's stage dependent there as well. And you mentioned Professor Herold, so this was the name in Mannheim who treated most of the fistulas there. And most often used treatment was the advancement flap as well. And then in more complicated stages there, you could do the suture. But I think it was very rarely used, the lift procedure, what I saw, very rarely. And of course, Alofisel was not used because not developed.
I forgot to answer one question. That was about which fistulas should be treated at a university or a tertiary center versus which fistulas should be treated at peripheral hospitals. I think you've lined out one group very nicely. Anorectal Crohn's disease. I think that to me is a group of patients that should belong into expert or high volume hands, and that are mostly tertiary referral centers. Not all of them are university hospitals, though. The second thing is which operations should be done in peripheral hospitals. I think many of them can and should be done in peripheral hospitals. In my opinion, nothing speaks against doing advancement mucosa flaps, lift operations, fistulotomies, all those operations in smaller hospitals. It's a medical setting that is very conducive to these hospitals. I believe there is a role for multiple failures. Those patients, I believe, benefit from second opinions, benefit from treatment at larger centers. And I don't see. Oh, here we go, Selim. Selim, maybe your experience in Bülach. Which of the fistulas did you treat there? Which of the fistulas did you send elsewhere?
Thank you very much for the question. I agree. The simple fistulas should be done in the center, in the peripheral hospitals, and those who relapse and those who had already multiple surgery and are in danger to lose their continence, there should be sent to centers, or at least be spoken or mentioned at the board to have or to get some recommendation how to treat them correctly.
I think that was a very important statement. The danger to lose continence. We know that with the number of proctologic operations, no matter what you do, but with an increasing number of proctologic operations, your likelihood of sphincter incontinence, fecal incontinence, will increase. So that's the same thing. I really believe patients who are at risk of becoming stool incontinent, they should be referred to centers with more experience. Any other question? If not, thank you very much again.